We are going live in 3, 2, 1, and go, sir. We are live now.
Good evening, doctors. I welcome you all to tonight's webinar titled Augmentation Strategies for the Treatment of Bipolar Disorder and Schizophrenia. I would like to begin by inviting the chairperson, Dr. G. Prasad Rao, who in turn would also introduce the moderator for today's evening program, Dr. Rukshida, and the speaker, Dr. Christopher Correll. Dr. G. Prasad Rao was the past president of Indian Psychiatry Society and is the deputy editor of the Indian Journal of Psychiatry, besides being the current president of IAGMH, the past president of IAPP, Bipolar Disorder Society of India, as well as the current president of the Indian Association of Biological Psychiatry, and is also the current president of the Asian Federation of Psychiatric Associations. Dr. G. Prasad Rao is currently serving as the director of the Psychopharmacology and Schizophrenia Division of Asha Hospital, Hyderabad. He has many illustrious achievements to his credit, namely the S. Pinakapani Gold Medal in Medicine, numerous best papers awards in psychiatry, the Lifetime Achievement Award received at the SARC International Psychiatry Conference in Kolkata in 2017. Besides, he was also awarded by the Andhra Pradesh government the Ugadi Puraskaram Award for Medicine on the 4th of April 2011 on the occasion of Telugu New Year's Day. Sir has also received many distinguished posts across a wide spectrum of psychiatric societies at the regional, zonal, and national level as well. Without much ado, I would hand over to you, sir, to take the program forward.
Thank you, Michael. It's really my great pleasure to invite each one of the members first for giving me the opportunity to share this wonderful session. We will not get so many occasions in a year when great luminaries like Christoph U. Correll, like towering personality, is going to talk to all of us. Before I introduce Christoph, it's my pleasant duty and to invite my dear colleague and a friend of a long time, Rukshida Saida. She is going to moderate the session. And for the sake of Christoph, I might add that we also have an Indian panel of a lot of doctors who will be participating subsequent to your lecture, in which we are going, after following your great lecture, we are going to have a discussion on the experience of cariprazine across our country, because cariprazine is right now available in our country for more than a year and a half. Rukshida is a consultant psychiatrist, psychotherapist, particularly interested in psychotherapy, which is probably rare in today's psychiatrists who are more of a biological orientation. Her specialties are, she would like to care much more for adolescents, young adults, women, and families of her psychiatric patients. She's currently the General Secretary of Indian Association of Biological Psychiatry. She's also the co-chair of Women and Mental Health in the Indian Psychiatric Society National Body. She is an executive council in the Indian Association of Private Psychiatry and also in the training section of Lokmanya Tilak Medical College. She is already an author on the median expert, and to sum it up, she's a great person. Now, it's my pleasant duty to introduce our speaker. Christoph, as I was researching myself to identify, he is a multinational person right now. And as we understand, though he works both in Germany and United States, right now he's in Canada attending the CINP. Welcome to this wonderful webinar meeting. Christoph is a professor of psychiatry in the Jakkar School of Medical Medicine, and which is in New York, USA, and also simultaneously professor and chair Department of Child and Adolescent Psychiatry in the Chahi University of Medicine, Berlin, Germany. I love the place Berlin quite well. I think I have visited more than 4 times till now. Thank you for accepting, Coral. Now, Coral has kind of a huge publications, and the count continues, and at this point of time, more than 850 articles which are published in the peer-reviewed journal. Not only that, at this point of time, it was cited at least 65,000 times, his research work, which speaks quite a huge impact he has on the scientific literature. He has won over 40 research awards, and since 2014 onwards, he has been in the most influential scientific minds and top 1% cited accredited articles, which goes on to say that he's one among the top few psychiatrists in the world who is recognized for his academic brilliance and science. As I start, the topic which he chose is a particular favorite of mine. We know none of our psychiatric conditions. Can I have the introductory slides, if you may? The topic is augmentation strategies for the treatment of bipolar and schizophrenia. And Christoph is going to tell us the most, probably the ideal rational polypharmacy as he goes on. And I expect, because he's covering the 2 most common disorders in which the conundrum always is both in the diagnosis, from the patient perspective, a lot of variables, from the treatment psychiatrist point of view, also a lot of conundrum in terms of identifying which is best for your patient. There are probably multiple reasons for polypharmacy. And there are a few people who actually have concerns, why should polypharmacy is there? And I'm sure in the next many minutes, he is going to talk to us and present what is best in the treatment. And I'm sure both the bipolar disorder and schizophrenia, the most chronic mental disorders, he is going to lend both the evidence base and also going to give us the bullet points of how best to treat our patients. Christoph, it's a pleasure to invite you here, and thank you for being with us. And the way it will go is, as you finish the lecture, we'll take the Q&A. And before Christoph starts his talk, I would request all the members who are participating in today's webinar, please post your questions in the chat box so that I can take note of them and put it to Christoph Coral as he ends his lecture. So may I now request Christoph to start his presentation, please?
Wonderful. Thank you so much for the very warm and welcoming words that I received. And it's such a pleasure talking to clinicians and experts from India. And as you mentioned, it is such a beautiful and rich culture that you have. I've been fortunate to visit India a couple of times already, and I'm always eager to visit it again. And Indian cuisine is among my absolute favorites, with all of the different shades and combinations. And that's what we will be talking about today, is mixing the spices, giving the right order for certain dishes of patients that need to improve and can only improve that way. Or do we need to be a little bit more monoclausal and causal? This is my disclosure information, and we are grateful for today's sponsor. And this is what I would like to cover with you so that we have enough time for question and answer, because I will have to go at 9:30 p.m. and then I understand you guys will have another session talking about the placement of cariprazine in the pharmaceutical armamentarium of treating bipolar disorder and schizophrenia, as this treatment is one of the latest to be approved, at least in the United States, for both bipolar mania, bipolar depression, unipolar depression as augmentation and schizophrenia, and it's obviously important to know where to place such medication, either in monotherapy or in combination. So I'll talk about augmentation, and let's start with principles of polypharmacy in general. Why do we combine? To combine or not to combine? That is the question. Well, sometimes when we combine the same medication, for example, 2 antipsychotics, it might be that we're still in the cross-titration period, either planning to continue it and it gets halted, or being on the travel to monotherapy. But then patients might actually improve. And then what you do? Do you continue to finish the switch, or do you say, well, maybe let's not rock the boat? That's as good as it gets. We also enhance the effect by combining. We might want to speed up the effect by maybe adding sedation to dopamine blockade, or having 2 different mechanisms of actions work together, which at the moment we only really have evidence for in bipolar disorder, because we have 3 different classes of medications: dopamine modulators, antiepileptics, and lithium. In schizophrenia, we have similar medications, although obviously they also block or stimulate different receptors that might actually lead to different outcomes. We might want different target symptoms. So maybe the one antipsychotic treats positive symptoms, but not negative symptoms, and we need to add something. Or one treats somewhat positive symptoms, but not agitation. So that's why we also use polypharmacy. It might be a different symptom domain. Well, what about depression? It's not within schizophrenia, so maybe we want an agent that also has antidepressant capacity. And that's why having antipsychotics that don't only treat psychosis, but also have antidepressant capacity, knowing that about 1/3 of people with schizophrenia have depression, and that the depressive episode is the main one in bipolar disorder in terms of longitudinal follow-up, it's important to not make depression worse by too much dopamine blockade and maybe improve it. We want to maybe reduce adverse effects by having 2 medications that sum up, having a similar chlorpromazine equivalent, but being at a lower dose, reducing side effects. We may want to combine a long-acting with an oral antipsychotic, or use different pharmacologic mechanisms, a full antagonist with a partial agonist. And I'll show you data from our meta-analysis that this seems to work for negative symptoms. There might be poor communication because people were destined to go to monotherapy but got stuck, and there might be preferences. Well, what are some of the concerns about polypharmacy? There might be more dose, more side effects, long-term side effects. When using a typical and an atypical antipsychotic, you might lose some atypicality. The risk of tardive dyskinesia might still be there. There are drug-drug interactions. Unclear whether there's increased mortality, but at least when adding benzodiazepines, we know that this actually increases mortality. We recently showed that, again, in the Finnish data set, but also when adding an antidepressant to an antipsychotic, we reduce mortality. Whether that's also the case when we use antipsychotics with antidepressant capacity, guarding against, especially in early phase patients, guarding against depression and suicide, needs to be further followed up. When you have too many medications and doses per day, there might be a risk of non-adherence. You don't know what really does what when you mix and match. There could be a higher cost. And for some of the combinations, especially in schizophrenia, there's not a great evidence base. So in schizophrenia, where the correlates of polypharmacy have been investigated much more, we can sum this up to save some time, that basically the correlates point toward greater severity, greater acuity. So one drug doesn't seem to be enough. So we want something else to speed up the effect, to augment the effect. And that means sicker patients often get more of the polypharmacy. But it may also be that it's therapeutic helplessness. Something doesn't work and we add something on and we add something on, rather than taking something away that wasn't working. So we may have to sometimes clean up the act. Provider factors are also different. There are differences, as well as medications. Clozapine might be related to more polypharmacy because we have treatment-resistant patients, But in those where it works, we may be able to get rid of some of the polypharmacy. But often we need to augment even clozapine. And I'll show you data that we analyzed from the Finnish data set, where a partial agonist added to clozapine was the only measure to improve clozapine's efficacy over monotherapy. There are system-related factors and others. Again, we need to identify when people come on two antipsychotics. What was the pathway? Which medication didn't work or needed to be augmented? Why was the next one given? So that we understand, is it a rational polypharmacy, or do we want to maybe look into making this one treatment reducing some of the medications? So the potential concerns are excessive dosing, side effects, drug-drug interactions. But again, there may be beneficial polypharmacy and not so beneficial polypharmacy. So let's look at the better evidence base, and that's in bipolar disorder. I already mentioned we have different medications with different mechanisms of action. We also have different targets, as summarized here, where we have the core symptoms, which could be mania, but it could be depression. So here we might even already need two medications, those that are better antimanic, those that are better antidepressant. Very few medications are true bimodal mood stabilizers. Quetiapine was the first, approved for bipolar mania, approved for bipolar depression. Now we have cariprazine, approved for bipolar mania, approved for bipolar depression. And in the United States, also lumateperone, but that's not approved for bipolar mania, only for bipolar depression. But we also need to treat comorbidities, both psychiatric, but also physical. We don't want medications that increase weight too much, that give metabolic syndrome. And in India, there is a big risk of metabolic syndrome. We also don't want too much dopamine blockade because that gives you sexual side effects. And especially in people with bipolar disorder, but also in people with schizophrenia, they do not really like that. It reduces the little pleasure they have remaining. So looking at mania meta-analysis, you can see that different agents work, and that includes obviously cariprazine. It includes also quetiapine in the upper range, and there's a nice overlap. So there's no really one treatment better than the other, including risperidone or olanzapine. Cariprazine very close to olanzapine, where many of us believe, yes, olanzapine is a potent medication because it also somehow gives sedation. But you don't need sedation. A 0.492 effect size, that's half a standard deviation difference with olanzapine, a 0.499 almost with cariprazine. Very, very close, being in the upper third of these treatment effects. These were the trials that led to the approval of cariprazine. And you can see that both the 3 to 6 and 6 to 12 milligram range, although we're now only going to 6, were significant. And we have no good evidence that the higher dose, 6 to 12 milligrams, was superior, but you can have more side effects, especially when you titrate every day by 1.5 milligrams, which was done in schizophrenia and bipolar mania trials, which may be too fast for some patients. Also because of the long half-life that cariprazine has, which actually is an advantage. Together with desmethyl and didesmethyl cariprazine, there's a 1-week half-life, meaning a very forgiving medication. When you miss a dose here or there, do a drug holiday over the weekend, not a problem, because it's a very long half-life. But what about looking at bipolar 1 disorder in terms of treatment acceptance? People voting with their feet. Will people stay in the treatment? And here again, cariprazine and quetiapine in the upper third of the acceptability, not having more dropout than placebo, actually less, because remember, acceptability combines efficacy and safety together. Looking at all-cause discontinuation, sorry, this was treatment response. I was blocking what I just said was treatment response. It was blocked by the video. So basically, very nice response rates with efficacy that is 60 to about 60% greater chance of response with the treatments, and very close olanzapine, cariprazine, quetiapine, 1.6 basically, 60% greater. Looking at treatment discontinuation, which is acceptability, not many treatments are actually in a way better than placebo. And here you can see that there was some improvement of less discontinuation with some agents, including quetiapine, whereas cariprazine, when dosed so quickly, can actually cause some dropout. So we don't, not greater than placebo, like placebo, but we may want to sometimes go a little bit more gingerly. And here are the data looking at combination treatments. Clearly, when giving two medications, an antipsychotic and a mood stabilizer, you get better outcomes in terms of treatment response compared to just the mood stabilizer alone, with an NNT number needed to treat of 5 to 7. And remember, any NNT that is less than 10, single digit, is not just statistically, but also clinically relevant. Looking at bipolar depression, here we have a supra rating, which gives you in a network meta-analysis the ranking. And so lurasidone and quetiapine shared the first rank together with olanzapine. And right after that was cariprazine, although it says 4, there's no number 1, because 1, 2, 3 are these treatments. And in a way, for MADRS, there was robust efficacy for all treatments. If you look at the CGI treatments, it's similar. And looking at depression itself, then here there was second rank for olanzapine, but many of the other treatments didn't really look at this. And for response and remission, again, we have efficacious treatments. Looking at side effects, though, here olanzapine is more on the later, basically not as good ranking as we know, and even quetiapine, being more sedating, also has somewhat more side effects, whereas looking at lurasidone, cariprazine, and aripiprazole, we basically have better rankings. Again, we need to individualize treatment with the medications we have available. We also need to understand what drives the bipolar depression rating. Here we have olanzapine and fluoxetine combined in red. That was better than placebo for bipolar depression, but we also have olanzapine alone being an antidepressant. But when you look at the line items, it seems that olanzapine in yellow only separates on inattention, reduced sleep, and reduced appetite, basically side effects. It didn't separate on reported sadness, apparent sadness, pessimistic thoughts, inability to feel, and so forth. So the sedation and weight gain, having the neurovegetative signs, can actually give you a pseudo appearance of efficacy. Now, this is not the case with quetiapine. Quetiapine also can cause sedation and weight gain, but it has a real antidepressant effect, being a noradrenaline reuptake inhibitor with norquetiapine, and also an alpha-2 antagonist leading to noradrenaline output. So we need to really look at this a little bit more in detail. And with cariprazine, which doesn't even cause an increase in weight and appetite, which doesn't sedate patients, there's a primary effect on depression, which we now know is not just in bipolar depression, but also augments SSRIs for unipolar depression. As mostly in patients on antipsychotics, the lower dose is generally the better one for bipolar depression and unipolar depression. So 1.5 to 3, not 4.5 to 6, which is the dose that we use in schizophrenia. And here you see, even when you have bipolar depression with mania symptoms mixed in or without mania symptoms mixed in, cariprazine very nicely separates from placebo in one study with 1.5 and 3 milligrams, and the other one with the 3 milligrams. In terms of side effects, we know that quetiapine and olanzapine can cause a lot of somnolence and weight gain. That doesn't happen with urazodone, cariprazine, or lumateperone, which are better tolerated. And the akathisia or EPS rate has a lot to do with the speed of titration. And the slower you go and the lower you stay, especially in depression and bipolar depression, the less you have an issue. Fortunately, the last 3 agents, urazodone, cariprazine, and lumateperone, have very little cardiometabolic side effects, which is really very important for longevity. We also need to consider, as I mentioned earlier, the bimodal mood stabilization that we like. And here, quetiapine is the closest to being both an antidepressant and an antimanic. This was done before cariprazine has shown its data, and cariprazine would be very similar, together with quetiapine, being a treatment that can both treat mania as well as bipolar depression. Lamotrigine, obviously, far better for depression. Risperidone, a dopamine blocker, better for mania relative to depression. This is not the relative efficacy across these agents. It is really where in the mood spectrum and the bipolarity do we have equal or unequal efficacy for both poles. We also need to differentiate unipolar from bipolar depression. That's not easy, but there are some pointers. Family history, early age of onset, frequency of episodes, shorter duration and faster onset, and seasonal affective disorders point toward bipolar depression. Multiple treatment failures and non-response, mania-like symptoms mixed in, and also an unevenness and too muchness in relationships, in work changes, and comorbid substance use disorders. So all of this should prompt us to either use the MDQ, the Mood Disorder Questionnaire, or the Rapid Mood Screener to really differentiate unipolar from bipolar depression. But there's also evidence that quetiapine and cariprazine are good for antidepressant effects, either in monotherapy or augmentation. Here are data from several trials, adjunctively or monotherapy with quetiapine. And here are trials with cariprazine that led to FDA approval very recently as an agent augmenting an SSRI, an antidepressant treatment, or as NRI with cariprazine. Again, giving us credence that this treatment is not just an antipsychotic or antimanic, it's also an antidepressant. And here are the studies that basically led to this approval. And again, the lower doses generally are more efficacious for depression. Now let's shift over to give us time for discussion to augmentation strategies for schizophrenia. This is much less straightforward because until now, we only have one basic mechanism of antipsychotic efficacy, which is postsynaptic dopamine blockade or partial agonism. Now, there may be differences for negative symptoms where partial agonism, serotonin antagonism might be helpful. So let's go through the yay or nay of antipsychotic polypharmacy. Well, clinicians vote with their feet. An average of 20% in our meta-analysis of patients in different settings are on 2 antipsychotics. The more severe the patients are, it may go up to 80% because we often do not use clozapine. We use antipsychotic polypharmacy instead. There might be diverse reasons, as I mentioned in the beginning, why 2 antipsychotics are combined. Randomized controlled evidence for efficacy of 2 antipsychotics is slim, and I'll go through those. However, there's also real-world evidence that we also contributed to that suggests maybe 2 antipsychotics are better than 1. But these are different ways of looking into the data, and we'll try to make sense of that. So this is our meta-analysis published in World Psychiatry, where we looked at the evidence and showed that, wow, remember that meta-analysis gives you a summary rating at the bottom, and whenever the diamond doesn't cross the vertical line, in this case for symptoms, the vertical line is 0, no difference. In terms of categorical outcomes, response or not, the vertical line is 1, that's the risk ratio. This looks to the left. Wow, this seems to be a half a standard deviation better. 2 antipsychotics than 1 favors augmentation. Maybe clinicians are right, but look to the left. This is driven by low quality, open label studies that analyze only completers. Everything is shifted to the left. I know that the patient is getting 2 medications. The patient is knowing that they get 2 medications. Very much biased. When you look at the top where there's blinding, some are to the left, some are to the right, and there's no significant effect. But you may say maybe there's a subgroup of patients that benefits most from 2 antipsychotics. So that's the responder status. Let's look at that. Again, in the open label studies, everything to the left with an effect size where we have 30% greater chance of having a treatment response. But when you look at high quality studies, the effect can't be even less significant. A 0.998 risk ratio and a 0.99 p-value. So it seems, at least in randomized trials, where patients might be sicker, where patients might not be as sick, there was no evidence for total symptoms or positive symptoms. But there was an evidence in high quality studies when adding a partial agonist to an antagonist, getting less negative symptoms. That's interesting because we have treatments for positive and total symptoms, but there's nothing approved for negative symptoms. So if you have patients with residual negative symptoms, maybe adding a partial agonist may be helpful. Then the question is, what about looking at negative symptoms per se? And we have very little evidence that medications work. Amisulpride only at low doses, but then at low doses, amisulpride is an antidepressant. It has a right and a left turning racemic component, and the right turning one is a 5-HT7 antagonist. That is an antidepressant. At higher doses, the left turning racemic form, that is an antidopaminergic component, gains traction. And then there's no evidence for negative symptom improvement anymore. At the bottom, you see an improvement for olanzapine over haloperidol. But again, this was very small. And EPS, which can give secondary negative symptoms, wasn't even measured. So the only treatment that has very good evidence without differences in depression or in positive symptoms, because these were positive symptom, almost free patients, are for cariprazine between 3 and 4.5 milligrams versus risperidone. 3 to 6 milligrams, but 4.5 milligrams was the modest dose. So here we have an additional indication that maybe not just the partial D2 partial agonism that was seen in our meta-analysis could be helpful, but what really distinguishes cariprazine, as you know, is D3 partial agonism. And that actually leads to, via D1, an increase in glutamate and dopamine output in the frontal lobe. That would predict better cognition and better negative symptoms. And at least for the negative symptoms, we have the data here suggesting that there is a clear advantage of cariprazine over risperidone. And here are the data for the negative symptoms. Very nice. Separation starts at week 14. But does that matter, that difference? Well, we have to look at functionality. And yes, it does. Even earlier than week 14, at week 10, there was already superiority of cariprazine over risperidone for functionality. And here is something very interesting. Even though it took 14 weeks for negative symptoms to separate, 10 weeks to separate on functionality, blinded clinicians already saw something at week 3, 5, 6. There was this little blurb here, but otherwise, throughout very early, a global illness advantage of cariprazine or risperidone. And risperidone is a very good medication. But here, even as early as week 3, clinicians feel something has changed. And that might be the light bulb effect, like people waking up, becoming more focused with their thinking, and also with their drive and affect being more related. Now, looking at outcomes not in randomized trials, but in real-world data sets, here Jari Tihonen in Finland found that in terms of prevention of hospitalization, long-acting injectables and clozapine seemed to trump other treatments. But there was also polypharmacy, 2 antipsychotics ranked in the first 10 best treatments. So we followed up on that and said, okay, let's reanalyze the data comparing polypharmacy versus monotherapy. And you can see the prevalent cohort left and the incident cohort from the first diagnosis on the right. And among the best 10 treatments, the only monotherapies were clozapine and a long-acting injectable. But most other outcomes were polypharmacy. Well, maybe because we continue patients who improve during the switch, but maybe some patients not entered into randomized trials can benefit from 2 antipsychotics. But look at the combinations. Most of them are with either clozapine or an LAI. So maybe here, cariprazine can play a big role because it's easy to combine, it has a long half-life, and it adds something that the other agents don't have, the D3 partial agonism that can also help with negative symptoms. But then the question is, when people are on 2 antipsychotics, can we stop them? And the answer is, well, overall, there might be some patients, here you see this. This is patients who stay on polypharmacy or go to monotherapy. About 70% of patients can keep monotherapy. But there is a subgroup of patients, more than those that are on polypharmacy continued over 6 months, that does relapse. So there is a subgroup that requires polypharmacy. And that's also what we see here in the meta-analysis by Bigali et al., that stopping versus continuing polypharmacy seems to favor continuation. And that is across all-cause discontinuation and also in discontinuation for inefficacy. So there may be some scenario clinically where 2 antipsychotics are warranted, even in schizophrenia. So let me summarize to give us enough time for Q&A. Polypharmacy is an established and approved treatment algorithm for bipolar disorder. We usually combine lithium with mood stabilizers, that's antiepileptics, lithium and antiepileptics with antipsychotics. We rarely combine 2 antipsychotics in bipolar disorder, and it's not needed. But the combination of different mechanisms of actions is synergistic. Now, looking at polypharmacy in schizophrenia, the data are much more slim. The receptors that are efficacious for psychosis are generally touched similarly, except for the partial agonism really separating from full antagonism. And here seems to be at least some advantage in combining the 2 for negative symptoms. And in the real-world data, combining a partial agonist also with clozapine, giving better overall efficacy for relapse prevention. But there's inconsistency, and we need to understand this better, pointing towards individualization of care. So although use of 2 antipsychotics may lead to drug-drug interactions, increased adverse effects, we need to balance this. There could be some patients that can benefit from 2. And we should really combine when we do different mechanisms, a full antagonist with a partial agonist, a sedating with a non-sedating agent, a fast off, that is like quetiapine or clozapine, with a tighter binding agent, which are the other agents. Clearly, an improvement during antipsychotic switching may be due to the combination of the two, but could also be due to the new medication. So trying to complete the switch before you discern that people should be on two medications might be the way to go. So let me stop here. Thank you for your attention and urge you to please participate in the COVID study, the comparative collaborative outcome study on health and functioning during infection times, www.COHFIT, C-O-H-F-I-T. We believe the largest study on the effects of the pandemic in the general population, children, adolescents, adults, with 185,000 people, less than 1,000 in India, less than 1,000 in India. So please go online, send it to family, friends, and colleagues, patients. We need to understand at every time of the pandemic how people are feeling. Thank you for your attention, and I look forward to your questions.
Thank you very much, Christoph. I would say in this, you have loaded quite a lot of information. It took me a while for me to dissect out what you're talking. I thought when you talked about logically why there should be a augmentation or a polypharmacy, you are given the various factors, and I'm sure they're all well documented, and that part was quite clear. When you started dividing into the bipolar depression, I'm particularly happy that you could give a clear answers on at least 2-3 evidence, which is a newer evidence at this point of time for the large Indian audience. Thank you very much for that. For example, to start with, to combine or not to combine is not probably the question. What to combine and how much to combine and how to go about is probably the answers which you gave. You went back to the history when you talked about the OFC combinations versus olanzapine, which were both efficacious versus placebo, but you gave a rational response why OFC is a better molecule than olanzapine alone, giving a documentation on the items of the. So augmentation of depression, and especially I'm particularly happy that you could finally give out a clear answer to our large audience that NNT of 5 for cariprazine and the other molecules which you quoted, both quetiapine from the large studies of Bolden and all. I think, but the other issue which we really learned today is much more on the schizophrenia, I would say. And I might quickly add, you did tongue-in-cheek did respond saying real world versus evidence. The reason why I thought I would bring this in clinical trials, obviously a lot of times, and when you brought out that beautiful meta-analysis of yours, which you tried to show to us, that meta-analysis actually you differentiated between good quality versus not so good quality, I would say, instead of saying bad. And then you, particularly I like the later part of your delineation on the negative symptoms. Yes, we don't really have any molecule. You quite rightly said amisulpride at lower dose might work. And you're right, at lower dose, it is an antidepressant too. So what is working, what is not working, whether it's a true negativism or pseudo-negativism, negative symptoms we are talking, is a good question. But towards the later part, you did give a very large argument, large evidence-supported argument, which I appreciate, that the partial agonists and within the receptor, if you combine properly and rationally, I think polypharmacy is the answer. So thank you very much. So before we go to this, I have my first question to. So today, I'm sure you are an evidence-based psychiatrist, obviously, based on the research and all. But in your real world, how many times you actually practice polypharmacy? For me, I practice every day for my schizophrenia patient. To start with, even if you give an antipsychotic and an anti-Parkinsonian agent, though carefully, we are doing a rational polypharmacy there. Or you give an antidepressant or an antipsychotic at some point of time. And today we have cariprazine and likes of those molecules. We might not do a polypharmacy. So I would like to start I would ask you to respond to this question. In your real world,
Yes, so I mean, in bipolar disorder, I would say my polypharmacy rate is 80%. In schizophrenia, the polypharmacy with non-antipsychotics is maybe 70% because they have an anti-anxiety medication, they have an antidepressant, but there's also polypharmacy within a pill. So I prefer those medications that have even antidepressant activity themselves. I personally try to avoid going above the neuroleptic threshold and adding on an anticholinergic. I rather go down on the dose or switch, because when we give an anticholinergic, we can slow down cognition and we can make tardive dyskinesia more likely. In terms of antipsychotic polypharmacy, I rarely use it. It's about 10 to 20%, and it's usually those that either are on clozapine or cannot tolerate or don't agree to clozapine. In non-treatment resistant patients, I try to really complete the switch and use other medications from other classes. This may change because you may have seen that there is a muscarinic agonist, xanomeline and trospium, that has now 3 positive studies. There's a muscarinic M4 positive allosteric modulator that has 1 positive study. So we may have a different class of medications that we can now rationally combine with current antipsychotics. But short of that, at the moment, I try to not use as much antipsychotic polypharmacy, except when nothing really works anymore.
Thank you very much. I think I'm with you on all the first 2 points. Yes, we do polypharmacy all the time for bipolar. We do quite a lot for schizophrenia as well. Dr. Sagar from Mumbai wants to know, what is the current level of evidence of cariprazine likely to produce tardive dyskinesia, or you can say protective action of tardive. Either way you can answer.
Yes, so basically we don't have yet very much long-term data on tardive dyskinesia, but we meta-analyzed incidence rates of tardive dyskinesia in World Psychiatry, Carbon et al., where we showed that the least likelihood of TD was with aripiprazole, a partial agonist, because we know from animal data that there is less postsynaptic upregulation of dopamine receptors, which might then become autochthonous and give rise to tardive dyskinesia. So most likely, we would apply the same to cariprazine, but we need more data.
Okay. What is your take on cariprazine prevention of suicidality? This is by Human has asked, we really have a data that, I know it is an antidepressant, so in a logical sense, we do expect an anti-suicidality. Do you have a good data on this, or what is your take on this?
Yeah, I mean, apart from the short-term randomized studies where depression improved and also suicidality decreased with the depression, apart from the long-term extension studies where we didn't see a rise in suicidality, we don't yet have long-term studies in cohorts. But whatever is antidepressant should, as you mentioned, have a shield against suicidality more than antipsychotics that don't have antidepressant activity and approval to a significant degree.
Another question from Human as well. What do we have at least some evidence that cariprazine works in rapid cyclers? You know, rapid cyclers are the big bugbears for most of us listening. What is your take on that?
Yeah, so rapid cycling means 4 or more episodes per year, which often go between hypomania or mania and a lot of depressive episodes. So for rapid cycling, what you want ideally is a most bimodal mood stabilizer, which basically keeps people from going into depression and keeps people from going into mania. And at the moment, the only treatments that have that dual efficacy are really quetiapine and cariprazine. I've been able to show you the data that there was equal efficacy in bipolar depression without mania-like symptoms, or bipolar depression with mania-like symptoms. So that would argue that there's maybe also efficacy for rapid cycling, but I haven't seen any study yet specifically subdividing it by rapid cycling status. But it's a good question. And if you have enough patients that you exposed, you can maybe write a case series to show that it also works in these patients quite better than what they had been on before if they were on non-bimodal mood stabilization.
My question here would be is in a typical bipolar rapid cycler, already the polypharmacy is there, usually 2 or 3 mood stabilizers. What would be the role of adding a cariprazine to that?
Well, I mean, the question is the patient stable? If the patient is stable on 2 or 3 mood stabilizers, don't rock the boat unless they are sedated, they have weight gain, they have sexual side effects. Well, then it might be good to bring in cariprazine. Or they have residual symptoms, or they say, doc, I don't want to take 3 or 4 pills a day. Then maybe by giving a bimodal mood stabilizer, you can move out after you establish that patients improve further or have maintained efficacy. You can then maybe take some of the medication that have duplicative effects on the antidepressant or antipsychotic side, anti-manic side.
Anti-manic.
But remember also, some patients have residual symptoms because we use antidepressants. And giving a bimodal mood stabilizer, you could maybe get rid of the antidepressant, and by doing so, potentially also take away some of the roughening of the course that can be given by antidepressant treatment.
I mean, I know we don't really have an approval for adolescents. So Dr. Amar Shinde wants to know, one, what is your experience of cariprazine? Because we have quite a bit of sensitive group there, both late children and adolescents who pass through, especially the mood dysregulation disorder, which we call it in DSM-5. So I would like your comment on whether you would like to use cariprazine and how much dose probably.
Yeah, that's a very good question. I mean, there are ongoing studies. Basically, they're requested to any sponsor who has an adult indication, unless they can argue this doesn't occur in children and adolescents, to do a pediatric study. There's an ongoing study for bipolar disorder and also schizophrenia. I've used cariprazine in adolescents. I'm both an adult and child and adolescent psychiatrist, and I've seen quite good responses. For me, adolescent brains that have bipolar disorder or schizophrenia are very close to an 18-year-old. Whether it's a 15 or 16 or 17, it's very much the same. Children may be different. So this disruptive mood dysregulation disorder, what you mentioned, I'm not sure. We don't have any data there for cariprazine, but sure, you can try to use it, especially. Remember, at the extremes of age, patients are more sensitive to side effects. So you don't want weight gain and metabolic syndrome early. You don't want dopamine blockade, which can even be associated potentially with breast cancer in girls in the future, also bone mineralization difficulties. But at the extremes of age, patients are also more sensitive to side effects. So start at 1.5 and wait at least for a week before you go up. Take your time. And stay between 1.5 and 3. If you have a very chronic patient or someone who has family history, you may go up to 4.5, but I stay usually at 1.5 to 3.
I might repeat once again, for a young children, let's say 20, in Indian children's weight is much less than 20 kilos. So do you recommend a dose of something like 0.5 to 1.75 to start with and stay there on a few weeks, say 4 weeks, and then go to a higher dose? Or you think you can go depending on, let's say, target symptoms, positive or negative symptoms of mood symptoms?
Yeah, I mean, with antipsychotics, we don't dose by weight generally. The dictum in kids is start low, go slow, but go. So go target symptom dependent, but don't go too fast. So I would say if it's pressing, you can go up every week. If you have time, wait 2 weeks before you go up.
I have just one more important question. What is your experience of using in the ultra clozapine resistant group of patients? Do you like to use, I mean, we have, for example, brexpiprazole, cariprazine, lumateperone in US. You are probably, I'm not adding the most recent molecule, because these 3 molecules are there for a few years. What is your experience in clozapine resistant among this, and what is your experience of adding cariprazine for clozapine? Any issues?
Yeah, I have good experience with adding the first partial agonist because it's been on the market for 20 years, almost 15 years, aripiprazole. And we have even randomized data that it seems to reduce metabolic burden and weight when adding a partial agonist to clozapine. And there's the naturalistic data that it reduces hospitalization. So based on those data, I have added cariprazine, and there are also case reports on that, to clozapine. And the car-clo combination is quite good. It's well tolerated. I don't see any issues in terms of drug-drug interactions. And we also know that clozapine is better for positive than for negative symptoms. So there are lingering negative symptoms. Also, there might not be enough of cognitive restabilization. So I've seen some good results by giving cariprazine, not in every patient, obviously, but it's a very hard population to treat. It's certainly something that one can try.
Your take on negative symptoms, pure negative symptoms. When I say pure negative symptoms, assessed by SANS, by Nancy Anderson scale, and you have a fairly significant high negative score. Do you use polypharmacy? Clozapine is one molecule, amisulpride is low dose is another molecule. What is your own experience on that?
Well, first, I would really try to weed out secondary negative symptoms. So if the patient has sedation, has EPS, sleep apnea, or also residual positive symptoms or depression, those 5 need to be ruled out and addressed. When that is the case, you have to see, can I switch? Is the positive symptomatology stable? So these are dopamine responders, dopamine blockade responders, and now I maybe move to monotherapy with cariprazine, which has the best data for negative symptoms. Or do I really need clozapine? Do I need the risperidone, a long-acting injectable? And then I can maybe add cariprazine to that backbone of treatment, trying to enhance the negative symptom efficacy.
Now I'll switch gears for a few minutes on bipolar disorder. We talked quite a lot on schizophrenia. Thank you for your inputs. My own question is, how do you manage a subsyndromal yet symptomatic bipolar? Especially I'm looking at, say, for example, this cariprazine molecule. How much of anti-manic or anti-hypomanic quality it has? It does have, we are sure about the antidepressant quality. Your comment on anti-hypomanic or anti-manic. Mania, I think it is somewhere there, but hypomania, I want your response much more. You can comment on both the things.
Well, anything that works for mania should also work for hypomania. It's less of a giant to try to get up. And some of the hypomania has to do also with this mood fluctuation between hypodepression and hypomania. So the bimodal mood stabilization should be quite good actually for that domain, and also help people sleep better and then hopefully have a better outcome long term.
I was looking for in your, because there is no subgroup analysis of the symptoms in bipolar. Impulsivity, do you think any of these newer anti-atypicals, do you find any of the molecule having something on the impulsivity?
Yeah, that's a great question. Obviously, impulsivity is a hallmark symptom of bipolarity and bipolar spectrum disorders, maybe including borderline personality disorder or agitated depression, substance use disorders, everything that's surrounding bipolar disorder. And it seems to me that dopamine stabilization has an anti-impulsivity, anti-irritability effect. But there's more data needed, absolutely. We haven't really parsed this well enough. And it's a very important symptom domain that's often not addressed enough and not researched enough. So thank you for pointing that out.
And last question from my side. I know I'm right on the time to ask you the last question. See, in bipolarity in India right now, especially among the youngsters up to 30, 35 years, we find a common comorbidity. And for your information, we have endoxifen in our country for the last 2 years, and we find that as a very good molecule. I want 2 comments on you. One, on the evidence base, endoxifen is just having a small role even in US FDA studies. So I'm sure you can't really talk too much about that. But among the atypicals, do you think any molecule, does it have a kind of a bipolarity with comorbid substance use, especially cannabis and alcohol? Any molecule data, it will be useful for us.
Yeah, so unfortunately, as you know, these patients are systematically excluded from randomized trial evidence. There is some slim evidence that there's good clinical evidence that these patients are not as adherent. So having long-acting injectables or long-acting oral treatments hopefully can help them in general. And they're also very sensitive to dampening their reward system. They want to have reward. They want to have the fire in the brain. And having partial agonism gives them at least some of this reward, but dampening too much of the drug effect when they binge. So there are some preliminary data that partial agonists might have some help there. And remember, some of the substance use is self-treatment for depression. So having also medications that help depression or prevent depression might reduce some of substance use. But we need better data. And if you have a cohort there, it would be very interesting to actually look at that with cariprazine or other agents and compare them.
Last question, lumateperone. We don't have it in India. Is it anyway different from, let's say, cariprazine, brexpiprazole, aripiprazole?
Well, it is different in the sense that it's a postsynaptic dopamine antagonist, but a presynaptic partial agonist. So it has less postsynaptic blockade, only about 40%. It's very safe, doesn't have akathisia, EPS, weight gain. It has some sedation and some dry mouth. So it's a very safe medication, but only one dose has been proven to be effective in schizophrenia, in bipolar disorder, and that's 42 milligrams. So you don't have any way of titrating. It's one dose only, so that's a big difference. And the half-life is much shorter than cariprazine or the other partial agonists.
You are talking from your experience, I hope.
Yeah.
Lumateperone, yes. Thank you very much. I think today we are more knowledgeable. Thank you for your elucidation of the evidence, teasing out the better studies to not so better studies in your real good meta-analysis. I'm really thankful for your time with us, and I'm sure hundreds of psychiatrists who are listening here, you have answered at least some of the doubts. I think we have a long way to go to get a most ideal mood stabilizer which works for both. But whatever we have, I think you really try to tell us. And of course, I try to get from you the real world evidence, which you try to give me as much. Thank you for your time and have a nice time in your CME conference.
Thank you very much for your time and the great sharing of this session. And I hope that you will have a good next discussion section on the potential role of cariprazine. Thank you for the opportunity to lecture this here today, and also maybe see you hopefully in India or somewhere else in the world in person.
In India, we'll call you to India very soon.
That would be wonderful. I love India.
And before I close, I think the background of your the art is so beautiful. Whatever it is, it's beautiful. Yeah. Thank you.
Okay. Thank you very much. Take care. Bye-bye.
So I would now invite Ruksheda, our young moderator, and she's always full of energy. And even before I finish, she has a question or she would a response. I'm sure we have a great panel here. Now it is all for you, Ruksheda. You take over from here. And I hope we got some good inputs from this. What I thought Ruksheda will take in the next 60 minutes or so, or even more, 90 minutes, up to 90 minutes, of course. What is the Indian experience and what is cariprazine all the way? And we have a great panel who have a rich experience. Sharmila is there. I could see Pradeep Joshi from Jalgaon. I could see Sagar, my dear friend, who has asked one interesting questions, and a lot of other people. As I take time, it's my pleasure that I think a lot of people. Kiran is also here. And I'm just looking for all the other people who will join. All the way, Rukshita. I'll be silent now onwards, keep watching all of you.
Thank you, sir. I'm not sure whether that's, we shouldn't take that as a threat, right? With Dr.
No,
Jia.
I'm not a threat. I'm just watching you. I'm just watching you. I'm learning from you. I want to learn from you.
No. This is now a performance under pressure. So all the panelists and the moderators geared up, and I think that's giving us extra energy. So we will keep that in mind. Thank you so much, Dr. Prasad Rao, sir, not only just for inviting me, but for excellent sharing, just like Dr. Corel said earlier. And his presentation was, I think, very lucid, very comprehensive. He made some great points. Also, I think by doing that, simply validated a lot of our everyday practice and practice-based evidence. With that, we have a couple of people missing from the panel today due to personal reasons. Having said that, we have a lot of representation from various psychiatrists from across the country, both old, new, and senior, and somebody like me who's a night owl. Having said that, I understand that it's already 9:30 and way past our dinner time. And so I'm going to try and not use 90 minutes, and hopefully we can have a great discussion, a very clinical based discussion before we start. At this point, I'm going to invite Dr. Aditi Popli. She's a young psychiatrist from Hisar. So Aditi, if you could share like a case, for a middle-aged adult of bipolar, maybe something that stays with you for any particular reason, how you may have managed it. If you could share a few insights.
Thank you, ma'am, for inviting me and giving me an opportunity to present some viewpoints about this molecule in my practice. I have been using it in few cases of bipolar disorders, and in middle age, about the age of, you can say the range of 30 years to 45 years, not too elderly, not too young. And what I've seen is that depending upon the patient's tolerability, even in fact as low as 1.5 milligram and as high as 6 milligram, both the doses are as effective in reducing the YMRS scales in the patients of bipolar mania as well as bipolar in bipolar mania. But as monotherapy, I am not much convinced. It is, I was using it along with the mood stabilizer, along with another second generation antipsychotic. And then the second generation antipsychotic that I was using, that I could taper down easily. And the side effect profile with cariprazine was very low in terms of weight gain and the other metabolic indexes, which the other second generation antipsychotics we have to monitor. The side effect profiles I didn't find much with the cariprazine. So on the whole, I think this is a good there's a good scope in this using this molecule.
Thank you so much, Aditi. The interesting part of it is the reason we wanted to highlight middle adults is because a lot of the times we do see people like that, isn't it? I mean, this might be the first time they would have come to a psychiatrist for treatment. Previously, either they were undiagnosed or untreated, or maybe badly treated by either a non-specialist in that area. So thank you so much for that. Can I invite Dr. Kiran Kumar from Mangalore now? I think, with the collective number of years that we have on this panel today, I think we have a lot of experience to share. Dr. Kiran, given the present availability of treatment modalities for schizophrenia, of psychosis, whether that's schizophrenia or bipolar, what do you think are the current challenges and maybe like the treatment gaps that we might have in terms of the available molecules that we have? I'm not going to go ahead and steer towards the somatic therapies, but just the molecules. What do you think? What are the challenges as clinicians when we're prescribing? What are we looking at?
Thank you very much for inviting. Of course, the challenges will be most of the time in the side effect profile of the antipsychotics, especially weight gain, sedation, EPS. Especially in ladies, we get galactoria. So considering it, like we also thought of caridrazine will be very effective drug. That's what we thought. So initially, when I started, generally I started with 1.5 milligram to 3 milligram. So I experienced a lot of side effects, like in the form akathisia. Akathisia, one of the major this one, as well as insomnia. So initially, I was very hesitant to start. In fact, I stopped cariprazine. Then some of my friends have said it's a very good molecule, and I restarted it, and of course, it went on well. But unfortunately, even 1.5 milligram, I used to have dystonias, especially in elderly people. Even severe dystonia I had at 1.5 milligram. So after that, I'm very careful with the elderly person. And young population, I went up to 6 milligram, then up to 9 milligram I have gone. Of course, it says that 6 milligram is the maximum. I went up to 9 milligram without any side effects. So I'm also a little, don't know what to do when patient is on 6 milligram. Should I increase the dosage or go for another antipsychotics? That was one more concern. And one more thing I noticed about galactoria. So I had one patient who was on quetiapine 300 milligram and cariprazine up to 4.5 milligram. So recent few days back, they have come with the galactoria. So I am not sure whether, because quetiapine also won't cause galactoria, so I'm not sure whether it is cariprazine or quetiapine. So I stopped the cariprazine and I had to wait and watch whether it is cariprazine induced or quetiapine induced galactoria. So these are the challenges which we face when we're giving antipsychotics.
Thank you so much, Dr. Kiran. We have Dr. Sharmila Sarkar from Calcutta. Hello, Sharmila. It was lovely to see you again. Sharmila, you wanted to share a case of a young adolescent with psychosis.
Okay. Actually, young adolescent with psychosis, first episode psychosis, we have to think several things. That is, it may go into schizophrenia, or it may develop bipolar disorder, or it may stay, or it disappear all the symptoms. Okay, so we have to think in that way. If the patient is a male one, we can use aripiprazole, we can use risperidone, amisulpride without any hesitant, or we can use any kind of atypical antipsychotic or even typical antipsychotic, depending on the present symptoms. That is, it is either positive symptom, most probably the patient at first episode psychosis presented with mainly positive symptoms, and if the patient is having a pre-morbid good adjustment and pre-morbid well functioning, then any antipsychotic can be used in case of first episode psychosis. But when there is a problem with premorbidity, like any patient having poor social adjustment, or having problem in socialization, or any functional impairment, that is problem in study or cognitive problem, then we can think about second generation antipsychotic, especially aripiprazole, cariprazine can be used. But I think the cariprazine is not till now is not indicated. FDA actually does not approve for adolescent person, but we can use, as aripiprazole is also safe for this patient. So to me, if the patient is having positive as well as negative symptoms and cognitive symptoms, as the cariprazine have some kind of pro-cognitive efficacy due to D3 agonistic activity, so I can use cariprazine in case of first episode psychosis with such symptoms. And I have used this molecule in first episode psychosis also. And the patient actually, two, three patients I have tried with first episode psychosis with this cariprazine, and I have seen good response. Only 1.5 milligram to maximum 3 milligram is required, and here often have to give propranolol, that is beta blocker, and clonazepam for treating insomnia, and also to treat the akathisia or the restlessness induced by this cariprazine. So cariprazine along with propranolol or benzodiazepine, that is clonazepam, is very useful in treating first episode psychosis in adolescent also.
Thank you so much, Dr. Sharmila. When you're talking about a young first episode and the questionable nature of the evolving symptoms and symptomatology, and then the diagnosis, from there, I would like to invite Dr. Sagar Karya. I think, here he and I were discussing about a case with bipolar depression in a young adult and his use and experience of cariprazine in particular in this case. Dr. Sagar is associate professor assistant professor at Sion Hospital in Mumbai, and a very, very useful guy to have around, and very good with his clinical skills as well. And he shares that he has a lot of experience with this particular molecule. Dr. Sagar, please share.
Yeah, so first of all, thank you for inviting me. At the onset, as you said, I have a lot of experience. I would like to share that I have used over more than 400 patients of cariprazine. And as well said by Dr. Sharmila and Kiran Kumar sir, that yes, the couple of issues what sir has raised, that is akathisia is the main issue. And I have also seen almost in 5 to 10% of the patients in these 400 patients suffering from akathisia. But madam has given a good suggestion that we use petril beta, that is a propranolol and clonazepam combination. And I get very less side effects because I, on the first day itself, give this combination of propranolol and clonazepam to tackle this akathisia. Now, coming to the question on bipolar disorder, I am very much happy to use it in bipolar depression and also unipolar depression. Unfortunately, I am not happy using it in mania when the patient is suffering from acute mania, because the dose what is required is a higher dose. And as Christoph sir has also said, that we can't start at a higher dose. We start with low 1.5, then we go 3 and all. So I think that tackling this acute manic episode is very difficult with cariprazine, but I'm very happy to use in bipolar depression, even as an add-on, and in unipolar depression where it is not responding to escitalopram. So just adding low dose of cariprazine works well. Coming to sir's query that it causes insomnia, yes, this is the main side effect which have come across, that patients do suffer from insomnia. So what I prefer to give it is in the morning. All of the patients will be in cariprazine 100. So whether it is 1.5, 3 mg or 4.5, give it in the morning. Unless rarely some patients will complain that yes, he is getting sedation. So in such patients, I will give it in the night, but maximum it will be in the morning.
Thank you so much, Sagar. We have Dr. Manish Kumar from Patna. Sir, thank you so much for joining. So when would you consider augmenting augmenting a second or maybe even a third molecule, whichever the molecule that you may prefer, if the person is diagnosed with psychosis, is already on an antipsychotic? When would you consider augmentation? What would be your indications for it?
Yeah, that's thanks. First of all, thanks for inviting me and giving such a wonderful question, because every one of us, when we are using antipsychotics, more than 50% patients, we do have to add some of the other molecule. Either we have to change our molecule. So there are two main pointers. First is the efficacy. Second is the adverse side effects. So once we start any medication, patient shows partial response, we try to increase the doses up to the maximum recommended dose. If then also the patient does not show complete response, we intend to augment the drug with second antipsychotic or residual symptoms with some other molecule. So the first is that poor partial response, the poor response to one antipsychotic. That is the first indication that we start augmenting. Second, if the patient has early side effects on certain molecules, because majority of these side effects, they are not dose dependent, they are idiosyncratic side effects. So in that case, either we need to stop at lower dose of medication, and then we have to either cross-stepper the first molecule, and we have to introduce the second molecule with which we can go at a higher dose. So these are basic two strategies. Third is any specific side effects that particularly hyperprolactinemia, patient has dystonia, akathisia, so that warrants the use of another either antipsychotic drug that we should introduce with the patient, right? So, and particularly in elderly patients or in pediatric patients, many times we are stuck because in pediatric patients, we many times require somewhat higher doses than the required. We start at a lower dose, we go slow, but we do not get proper response, and we are afraid that we should not use a higher dose of medication. In that case, we can obviously augment low doses of medication with another low dose of antipsychotic so that we remain safe in tackling the side effects.
Thank you so much, Dr. Manish Kumar. I think that was so very well put, and I can see that you're an excellent teacher. I'm sure your students are very blessed to have you. We also have a senior psychiatrist, Dr. Pradeep Joshi from Jalgaon. Sir, if I could ask you, invite you to share your insights. What is your experience with cariprazine? How would you place cariprazine in terms of either Qutipin, aripiprazole, or cariprazine? What is your experience, and how do you like to use it? You're on mute, sir, or we can't hear you for some reason. I think it's your audio. If you can actually remove your, yeah. No, I'm sorry. Unfortunately, we still can't hear you. Sir, I can come back to you with the same question. If you want to leave the meeting and come back again, maybe that will help you rejoin the audio connection. I'll save the question for you, sir. So I think it would be easier if you leave the meeting and then rejoin. We also have Dr. Prashant Agarwal with us, who clearly has a very, very busy practice and even now is joining us from his car. Thank you so much, Dr. Agarwal, for joining us. If you could share what are the cases that you've used cariprazine in, to what outcomes, a different range of maybe diagnosis and symptoms, if you could share your experience.
Good evening. Thank you for inviting me. First of all, I want to say that I started cariprazine when it was launched by other pharma company. So I have started it in so many patients, around 200, more than 200 patients. And what I have seen is that most of the patients, those who have shown response to cariprazine, those were actually suffering from schizophrenia, either schizophrenia, second bipolar depression, middle-aged females, those who are suffering from bipolar depression. So I used cariprazine when I was giving some other molecules like olanzapine. I shifted them to cariprazine, and then gradually I stopped cariprazine. So most of them, they all are okay, means they have no problem. And I have also used cariprazine when I wanted to stop, means after 2 years of treatment, when I wanted to stop the molecule which I was giving, that means either olanzapine or clozapine or sometimes aripiprazole. So in those patients, I have used 1.5 milligram cariprazine, and gradually I tapered it to 1.5 alternate days, and then I have stopped. So most of the patients, they all are good, means they don't have any symptoms of psychosis or depression till now, but a few of them, around 20% of the patients, they developed symptoms again. So this is my experience, I think. And I haven't increased the dose more than 1.5. Means most of the patients, they have shown response to 1.5 only. Very rarely, I think 5 or 10 patients I have, in those I have given 3 milligram, but not more than that. So it shows response, and I have seen most common side effect of cariprazine is akathisia, especially in young females, those who are suffering from bipolar depression. When I have given them cariprazine, even in low dose, they reported akathisia, inner restlessness. So even when I added propranolol, they haven't shown response. So, but in middle-aged females and in schizophrenia, it has a very good response. So these are my experiences. And second thing, I haven't seen any kind of insomnia because I prefer to give cariprazine at night. So before sleep, 001. But none of my patients, they have shown any insomnia kind of thing till date. So these all are my experiences.
Thank you so much. Thank you so much. We have Dr. Joshi again. Sir, I'm going to ask that again to you. If you could share your experiences, cariprazine, especially with comparison, how Q-tipin is used, or maybe even aripiprazole is used.
Am I audible now?
Yes, perfectly.
Oh, thank you, madam. Yeah, actually, my experience with cariprazine is not as vast as some of the psychiatrists who have experience of almost 400 patients and also. But whatever my experience is, I find that cariprazine is a very useful drug. Particularly, I will tell you about one case about because of the low side effect, the patients adhering to the treatment, possibility of patients adhering to the treatment increases to a lot of extent. I had one patient who, young female patient, and who had a psychosis, but she refused to continue with the treatment because of the side effects, because of the sedation, because of the weight gain, and her psychotic symptoms went on relapsing. Then I put her on cariprazine only as a monotherapy, and she accepted that cariprazine very well. And after that, she continued with the cariprazine regularly, and she didn't have any relapses after that. So that is the one very good point. I feel that in young ladies, cariprazine is a very good molecule, particularly because of its side effect profile, and it is very useful. I had this question in my mind whether how to compare the aripiprazole and cariprazine as such. I find both are equally effective and almost equally accepted, but cariprazine is accepted more rather than aripiprazine as such. Q-tipin is no doubt is a good molecule, and particularly because it has got more sedation, it stands apart from this cariprazine and aripiprazine as such. But all the three molecules, though effective, I have a lot of hopes from cariprazine that it will be a very effective and widely used molecule in the future. That's what I feel.
Thank you so much, sir. I think you validated a lot of clinical experiences of all the, not only just the panelists here, but also the delegates who are listening in. Sharmila, on paper, it does seem like cariprazine should be a prolactin sparing agent. Have you, in your experience, especially treating women with it, have you seen that that might be a better option for people, women maybe with PCOD and maybe PCOD related agitated depression, maybe? Have you any experience in that field?
Yes, one of my patient who was on risperidone, one risperidone and also amisulpride, they actually had hyperprolactinemia issues. That is, they have menstrual irregularities, and also when I tell them to investigate for prolactin level, and it shows that there are the hyperprolactinemia was there, and I shifted the molecule into cariprazine, and the patient actually become symptomatically better, and also they have reduced prolactin level, but it takes time. Means about 4 to 6 weeks it takes to reduce the blood level, that is that to goes down to a baseline level of hyperprolactinemia. So this is I have used in aripiprazole, amisulpride and risperidone induced hyperprolactinemia patient cariprazine, and it shows a significant improvement. Both the means hyperprolactinemia, control hyperprolactinemia, also the symptoms also improve.
Thank you. Sagar, I wanted, you and I were talking about your use, effective use of this particular molecule in depression and unipolar depression. Would there be a difference in gender in terms of, efficacy or a better outcome in men versus women?
No, clinically, I have not seen any such gender differences or age differences. Irrespective of, means the clinical profile is very important rather than the gender or the age, what I feel. Even as someone had asked me whether we can use it in children or adolescent and other population, I have used in youngest patient is of 8 years. So, and it's safe without any side effects. And it has a good action in patients with autism with behavioral issues. So that category of patients are responding very well with cariprazine, and it's very difficult to control self-mutilating behavior and other aggressive behavior in autism or ID children, intellectually disabled. And cariprazine seems to be a safer option, one because once a day dosing, so easy to give, non-sedating, no weight gain, because this ID and autism children have a lot of side effects with other molecules, like they keep on eating. As such, they don't know when to stop eating, and with olanzapine and all, their appetite increases a lot. So patients, the relatives are very worried about it. So cariprazine is a good option in such patients. And as I said, no gender differences, equally well responsive.
Would you use that as an antidepressant without it being an augmenting molecule?
In monotherapy, in my this clinical practice, I have used as only in schizophrenia, not in depression. Depression as an add-on, always with some of the other SSRIs or SNRIs.
Thank you. Dr. Aditi, do we still have you on? Do we still have you around? Okay. Dr. Kiran Kumar, we all are talking about akathisia, but I have seen in my experience the extrapyramidal effects, the movement disorders also being a huge part of the side effect profile. I don't have 400 patients that I've treated with them. Having said that, those have been my experiences. But we also do understand that apart from the akathisia and maybe the extrapyramidal effects, it could be QT sparing. So would you think that this would be a replacement for Qutipin, which is more, which is more notorious for the QT interval infractions there? I'm sorry, sir, you're on mute.
Definitely, cariprazine has a role when we're talking about the QTC prolongation, as quetiapine affects that. But if you're considering sedation part, sometimes we need sedation for some patients. So quetiapine is a better option. And even an elderly person, as I said, even 1.5 milligram of cariprazine, I had experienced severe dystonia in one of the patients. So in elderly persons also, it's finding very difficult to maybe go on cariprazine. Quetiapine again has a good role. But overall, as we said, the cariprazine replacement, when we need data molecule or risperidone, I generally do when I shift out from risperidone, I shift to cariprazine. But when they're doing well on quetiapine, I don't change.
Thank you so much, sir. Dr. Joshi, earlier Dr. G. Prasad Rao sir also mentioned that maybe there's a possible space for impulsivity, but it's also supposed to be a very pro-cognitive kind of effect. So do you think that there may be some amount of space for cariprazine, especially in younger adults, or like, Dr. Sagar mentioned with ASD, where it might be helpful in terms of, not just mood stabilizing because, it's a partial agonist, but also maybe impulsivity and not OCD. We're not talking about OCD, but we're talking about more neurodivergence. Do you think there would be space for that? And is that something that you may encourage us to explore?
Yes, certainly. I think there is a space and it must be explored because we need antipsychotic drugs which are safe in treating this group of patients, particularly in children. We have to go for that and have more studies and more experiences particularly in this particular group.
And so what is the oldest person on cariprazine that you have tried the molecule on? Sagar has said the youngest was 8.
What I feel, in fact, I wanted to add this point before also, that in elderly patient, it is said that it doesn't need any adjustment of the doses. And the doses are actually just like the adult dose as such. But when there is a kidney and liver problems, you have to start with lower doses. What I feel that even if it is like that in Indian population, we must be aware that we should start with much lower doses than normal doses in elderly people. And the problem with cariprazine is the titrating the doses is a difficult thing, particularly when we start with 1.5 milligram, even in any patient, they say that you should go to 3 milligram next day. And so on the second day, if you want to shift the patient to 3 milligram, you usually don't ask the patient to buy only one capsule of 1.5 milligram and rest of the 3 milligram. I think there should be proper chance of titration because it is a capsule, we can't break it. So if it comes in the tablet form, I think it will be more convenient to adjust the doses and start it from the lower dose as such. As far as maximum age, no, not very old patient. I haven't started put the patient on the very old cases or senile patients, but elderly people, say 50, 55, I have tried up to that.
Thank you, sir. So just like as a last kind of like round of questions, I'm going to pose the same question with different kind of indications to each of the panelists. What would be your first drug of choice and what would be the choice for augmentation drug in these particular cases? So I'm going to start with Dr. Prashant Agarwal now that he's finished his travel and nicely cozily sitting there. So Dr. Prashant, what would be your first drug of choice and if required an augmentation drug of choice in a person with psychosis with negative symptoms?
First drug of choice is always olanzapine. Second, if there are more prominent negative symptoms, then I always go for amisulpride. So I have seen remarkable response in the patients. But yes.
First, for any psychosis or particularly for negative symptoms?
Particularly for negative symptoms, but for all psychosis, I prefer to start olanzapine. But when there are prominent negative symptoms, then I go for amisulpride up to even 1200 milligrams.
1200 milligram of amisulpride with 20 milligram of olanzapine?
Initially, I start olanzapine. If patient doesn't show any response, then I taper off olanzapine and shift them to amisulpride. Then I gradually increase the dose up to 1200 milligrams. Right. And most of my patients, they are all well.
those who are having negative symptoms.
Right. So thank you so much. Dr. Kiran Kumar, now that Dr. Prashant said that 1200 milligram of amisulpride and my radar goes off that, oh my God, I can't think about what's the prolactin. So in your case, if you had a woman in a reproductive age group with psychosis, whether schizophrenia or bipolar, requiring an antipsychotic, what would be your first choice of medicine and what would be your augmenting drug?
Yeah, during, of course, I used earlier aripiprazole, but nowadays I started cariprazine since theoretically it shows that there is no galactoria. In fact, some of the patients who are on risperidone who had developed galactoria, I stopped the medicine and started cariprazole. It's a very short duration to say because it's only 2-3 months. They never had, none of them had galactoria except one patient, as you already told, who was on 300 milligram of quetiapine and cariprazine. So in that case, I am not sure whether it is quetiapine or cariprazine. But most of my patients with the cariprazine never had galactoria. And as I said, it is very short because it's only 2-3 months they are shifted to cariprazine. So only time factor has to say, because when we give risperidone also, first few months, some people do not develop galactoria. It's not all patients that develop galactoria. In the same way, in cariprazine also, I used 2-3 months. They have not had, so we have to wait and watch to say really whether it is not affecting galactoria. Thank you.
Thank you, Dr. Kiran Kumar. Dr. Sagar, what would be your first drug of choice for first episode psychosis of any kind? And what would be your choice for an augmentation drug?
Always first drug of choice is olanzapine, unless the patient is having prodromal syndromes. So there I would prefer cariprazine because that's a good, safe alternative now which I have. And augmenting agent is either blonancyrin or then I directly start with clozapine. If he is really very bad and all, then I start with clozapine then.
But you would use cariprazine as a first choice.
Where the symptoms are very important, like not for positive symptoms, more for the negative symptoms.
Yes, yes. Dr. Sharmila, with a person with a history of movement disorders, with any kind of, whichever may be antipsychotics in the past, what would be your A, drug of choice, and B, drug of augmentation? We're assuming that the patient requires augmentation.
So the patient must be having some kind of antipsychotic medication so that he or she has developed movement disorder. So I have to stop that medicine and will change to either quetiapine or olanzapine. If the patient is having metabolic syndrome, then I will definitely not go for olanzapine. I will prefer quetiapine. And sometimes we have to choose, we have to give clozapine also in case of if the patient is having dyskinesia. So this will be preferably I will give quetiapine, and augmenting agent I can have aripiprazole or cariprazine.
Thank you. I think Dr. Aditi is around, but not around. I don't blame her. It's already 10:15. Dr. Joshi, you did mention we do have a lot of older adults with pre-existing either metabolic conditions or maybe a bad cardiac profile. So in cases like that, maybe not in senile dementia, but maybe, psychosis for other reasons, what would be your first drug of choice for as an antipsychotic, and what would be your augmenting choice?
In elderly patient, I will first try risperidone as such. And if with risperidone, if patient develops side effects, then only I will shift to another drug. And this another drug will be basically quetiapine.
Thank you, sir. Dr. Kiran Kumar, would you use cariprazine as an augmenting drug in somebody with more aggressive symptoms of whether psychosis of bipolar and a mixed syndrome, a mixed episode, or maybe even psychosis? Is there any space for cariprazine and as augmentation for aggressive symptoms?
Yeah, definitely. I think because it's efficacy wise, it is so. I have not used as such cariprazine in severe aggressive patients because we are not that confident of this molecule. But theoretically, or how it is responding to psychosis or schizophrenia, definitely it has a role for severe aggressive patients.
Thank you. Sagar, last question for you again, especially because, you did tell us that you have 400 patients on it. So we're assuming you have the maximum number of experience here. With people with history of sexual side effects, whether that was because of the disorder, because of the medications, we might not know that. In those cases, what would be your treatment algorithm that you would choose to follow?
Yeah, I would first control the psychosis with my routine line of management, that is olanzapine, clonazepam, clozapine. And if still the patient says, I am still having the sexual side effects, decreased libido and all, then I would consider adding aripiprazole or cariprazine, because initial stage, as I said, I don't add because the lower doses are not going to help in the positive symptoms. So once is maintained and all, in maintenance phase, I would like to add either aripiprazole or cariprazine. Aripiprazole better because it has been shown to increase the desire and the libido. Cariprazine, I have not yet seen that efficacy in increasing the libido as such.
So thank you so much. I do know that we don't have any kind of FDA approvals for use in pregnancy. Having said that, are there any panelists here who've used cariprazine in pregnancy, particularly whether as a standalone drug of choice? I can see a lot of shaking of the heads and no.
Because theoretically should be avoided definitely in pregnancy.
Right. Any role of substance use or substance use disorder or dependence with mood lability and use of cariprazine? Do we consider that maybe first line in these cases, or maybe as an augmentation? Anybody can answer that. It's an open question.
Yes, comorbid with schizophrenia and mania with substance use, it has a definitely good role. Independent substance use, I have not tried, though G. Prasad Rao sir is there, Zonalta or the endoxifen has been used in the independent substance use, but not cariprazine yet.
Thank you so much. I'm not sure whether Dr. G. Prasad Rao has completely abandoned us or is still that we're doing in terms of discussing and sharing and learning by sharing. With that, I'm going to hand over the session to our organizers. And thank you very much for this opportunity to interact with so many psychiatrists from across the country. And the sheer number of years, if we all put together our experiences and number of cases, it just boggles the brains. And at 10:15 and 10:20 in the night, I'm really, really appreciative that all of you all have been patient with us, and nothing like I said, sharing to learn and improve our clinical skills. And with that, Michael's going to attest to the fact that I don't quite use cariprazine as much, but after this session, hopefully with more learning and more experience, a vicarious experience from all my colleagues, I might be a little bit more encouraged to use it. So job well done, I think, Intas, and over to you guys.
Good evening, doctors, at the very onset. Am I audible?
Yes.
Yes.
At the very onset, I would like to thank the speaker, although he's not here, Dr. Christopher Correll, for his very engrossing presentation on the augmentation strategies for the treatment for bipolar disorder and schizophrenia. I would also like to thank the moderator, Dr. Madam Rukshida, who in her own amicable style has drawn out insightful feedbacks on the clinical experiences from all the panelists, which was truly enriching for us all. I would like to thank the galaxy of well-accomplished, highly experienced panelists, namely Dr. Kiran Kumar, Dr. Aditi, Dr. Sagar Karia, Dr. Sharmila Sarkar, Dr. Shinde, Dr. Manish Kumar, Dr. Prashant Agrawal, and Dr. Pradeep Joshi. Last but not the least, my sincere word of thanks goes to the chairperson, Dr. G. Prasad Rao, whose valued presence in summarizing the key relevant take-home messages and insightful comments has made this program an invaluable learning experience. I would also like to thank the 700 attendees who have taken out valuable time to attend tonight's webinar and have truly helped in making tonight's webinar a grand success. Thank you to all of you, and a good night. Thank you, all of you.
Thank you. Thank you.
Thank
Good
you.
night.
Good night.
Thank you, Rukshida and organizer. Good night.
Good night. Good night. Good night. Thank you.